listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1, questions 1 to 12. You hear an eye specialist talking to a patient called Jasmine Burton, who has recently undergone eye surgery. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
I've got your notes here, Mrs. Burton, but as we're meeting for the first time, could you begin by telling me a little about your eyesight and the treatment you've had over the years? Did you wear glasses as a child, for example?
Yes, since I was about 7. My parents were concerned by the way I held a book when I was reading, so they took me to an optometrist. He told them I had some kind of astigmatism.
Am I right in assuming that's myopic rather than hyperopic?
Well, yes, I'm nearsighted, if that's what you mean.
That's right. Some people actually have mixed astigmatism. They're farsighted in one eye and near in the other.
Oh, well, that's not me.
Right.
And as well as my astigmatism, as you probably noticed, my eyes flicker. I'm not aware of it myself, but other people comment on it sometimes. I think you call it nystagmus. It meant that when I had my eye surgery, they preferred to use a general rather than a local anaesthetic.
Okay, so did anyone ever tell you what they thought might have caused the condition?
Well, I was once told that my generally poor eyesight is most probably down to the fact that I don't have enough pigment in my eye.
Right.
On the whole, my eyes have never really caused me any significant difficulties, however. I've always had to wear glasses, so that's part of life now. I suppose the only thing is that driving's always been out of the question. I'd never have passed the sight part of the test. That's probably a good thing because it takes me some time to focus, which could make me pretty dangerous if I was ever behind the wheel of a car.
Yes, indeed.
Also, I'm useless at sports like tennis. I think that's because I'm poor at judging the distance between myself and the ball. That was a pain as a teenager, but I've never particularly wanted to play since then. And I've hardly had any issues at work because of my sight. I'm a receptionist in a hotel, and I've never had any difficulty reading computer screens or anything, fortunately.
You've had your eyes regularly checked throughout your life, presumably.
Yeah, that's right, every couple of years. My prescription has changed a little over time, but not that much. Though I certainly couldn't manage without reading glasses these days. About 3 years ago, I was told a cataract was developing in my right eye.
Right.
It was a few years before they decided to remove it. That was this February, and it all went very smoothly.
Good. And you were pleased with the result?
Yeah, I was, thrilled. If only all our failing parts could be replaced so easily. However, when I had the routine checkup a couple of weeks after the operation, I was told there was some clouding. Opacity?
Opacity, yeah.
I think was the word they used, in the capsule containing the new lens. It's a bit disappointing. They could clear it with a laser if it gets to be a real problem, but my flicker makes that rather a risky option. I knew that there's a greater chance of developing a detached retina after a cataract op.
Yes.
But I'm glad to say they found there wasn't any evidence of that in my case.
Oh, good.
All they did was make an appointment for me to be checked out again in 6 months' time. But they said I should get in touch if I felt concerned about my eyes.
And is that what brings you here today?
Yeah, because I am bothered about a couple of things. So firstly, I've noticed more floaters than usual.
Right.
I don't know if that's something to worry about or not. More annoying is the fact that I'm much more troubled by glare than I used to be, so I wanted to ask your opinion on that.
Okay, well, let's start by...
Extract 2. Questions 13 to 24.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Welcome, Mr. Thomas. How are you feeling today?
Well, about the same as last time.
Let's just take a few moments to review your symptoms before getting to the investigation results.
Yes, so I mentioned last time I thought I had gained some weight, and it appears to keep going. I mean, now my face has become very round, and I have this, what I think is a fatty deposit between my shoulders. It's not a good time for my body image.
And what about the stretch marks that you started noticing a bit before our last appointment?
Yes, that is still there, and now it has spread up my abdomen and down my thighs. I've also noticed that a cut I got working outside is taking forever to heal. I'm not sure if that is related to all of this, but it is quite alarming.
And in general, what is your energy level and your mood like?
Some days I am not sure if it is severe fatigue or depression or a bit of both. But there is a real struggle to get out of bed these days. Also, I'm somewhat afraid to be around my grandchildren because I just feel so irritable all of the time. I mean, the other day I lost my temper over the simplest thing.
I see. So it seems like your physical symptoms are definitely getting worse, and these are affecting your mood somewhat.
I think that is definitely true. So what about those investigations, Doc?
Well, as you probably recall, we carried out quite a few diagnostic investigations. There were the urine and blood tests. With the urine test, we were particularly interested in the cortisol levels. We also had you help us conduct a saliva test to check for cortisol levels as well.
Yes, that was a bit intense, collecting urine over a 24-hour period and then having to remember to get a sample of saliva in the evening.
Yes, so the 24-hour urinary cortisol investigation showed cortisol excretion of more than 3 times the upper limit of normal, which is strongly suggestive of Cushing's syndrome. The late-night salivary cortisol measurement confirming this finding.
Okay, so I understand the high levels of cortisol, and now you're saying they cause Cushing's syndrome? What does cortisol do exactly?
Well, cortisol plays a variety of roles in your body. For example, it helps to regulate blood pressure, reduces inflammation, and keeps your heart and blood vessels functioning normally. It also helps your body respond to stress.
Sounds like serious stuff.
It is. The condition is associated with significant morbidity and mortality, so rapid diagnosis and management are essential.
What exactly would happen without treatment?
Well, there would be bone loss, which could result in unusual bone fractures, and also high blood pressure and type 2 diabetes. Other possibilities include frequent and unusual infections and a loss of muscle mass and strength.
I see. So what causes something like this? Cushing's syndrome?
Well, there are a few different causes, but the most common cause is the use of corticosteroids like hydrocortisone or prednisone over an extended period of time. However, we can rule out corticosteroids in your case because you are not on this type of medication. That leaves your body's own overproduction of cortisol. This is also known as endogenous Cushing's syndrome. Here there are still a few possibilities, including a pituitary gland tumour, an ACTH-secreting tumour, or a primary adrenal gland disease.
And so how do you find out which one is causing my problem?
Well, there are a few more investigations to be done. First of all, one to detect plasma ACTH. It is also necessary to get an MRI of the pituitary and a CT of the chest and abdomen. These will help us to identify the presence of a tumour.
So now that you have me all scared, what are the treatment options?
Well, that will depend on the cause, but there are medications that can be used to temporarily reduce your glucocorticoid levels, which would help prepare you for definitive therapy. Surgical management is a likely option, particularly if the cause of your Cushing's syndrome is an adrenal or pituitary tumour.
Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a doctor briefing his colleague about a patient.
Have you got a list of all the patients and locations?
Yeah. Who is our sickest patient?
Mr. Marcel is the sickest patient. He is a 36-year-old male with a ruptured appendix awaiting OR. He became sick over the last 48 hours with worsening abdominal pain, nausea and vomiting. We gave him fluids and brought antibiotics.
Which antibiotics and how much fluid?
Piptazo with 2 liters of normal saline so far. Imaging showed a ruptured appendix with free air under the diaphragm. I would keep a close eye on him.
Have you drawn blood cultures?
Yes. But they were drawn about an hour after antibiotics were started.
And what are the plans if there is a delay in surgery?
I haven't spoken to ICU yet, but he might need to go there if his condition worsens while he is waiting for the OR. Sound good?
Yeah, I'll speak to ICU as soon as we're done here.
Question 26. You hear part of a surgical team's briefing. Now read the question.
She currently only has intermittent late decelerations, and these have improved with her position changes and supplemental oxygen. We'll monitor her until she's fully dilated and
evidence of fetal distress or persistent late decelerations. We should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use them.
Great, I'll discuss this plan with Mrs. Aldrich, and we are done here. What are her vitals right now?
Normal. I just checked 15 minutes ago. She had no late decelerations since you were called.
Question 27. You hear a radiologist talking about a new initiative that has been introduced. Now read the question.
This is a big, ambitious project. We're going to focus on patient flow through the system right from the very start. When a patient sees their commission and they require support from radiology with imaging and they make a request, We want to get that request from imaging as quickly and as efficiently through the system to the reports available to the Commission, so they can make the appropriate management plan and take the patient's clinical journey forwards. This is an ideal opportunity now to really embed some forward behavior, where we're learning together, we're developing together, we're looking at creating where we have today's work completed today, that there's no delay, so we're really improving the services to our patients. We are all taking control, we are all involved, and we will be proactive and not reactive, so we have analyzed CT and MRI services. We have outlined and prioritized areas for further improvement, and you can make a difference.
Question 28. You hear a pharmacist talking to a doctor regarding a patient's medication. Now read the question.
Hi, Dr. Marcy, is this a good time? I need 2 minutes to discuss about Mrs. Samuel. I'm Harper and I'm providing pharmacy coverage to the unit.
I have a few minutes. What's up?
Nursing raised a concern from rounds this morning. The situation is that Mrs. Samuel's pain isn't being well controlled. She's sedated, which is having an impact on her participation in therapies, and she's continually reporting her pain at 8 out of 10.
Okay. What's the background of the patient?
She has fallen 3 times since her admission to rehab, and she's requesting to go home at her first pass this weekend, some big family anniversary. But my assessment is that we are not adequately controlling her pain, and what we're giving her is contributing to these falls.
Okay, so what do you recommend?
Well, after reviewing her chart, I'm considering lowering her dose of opiates and introducing an anti-inflammatory which would be less sedating and she should be able to tolerate.
Yeah, that makes sense.
Her husband is coming in this Tuesday at 9 a.m. if you're available. We could meet to discuss.
Okay, sounds like a good plan. Let's meet back here and we'll talk to the family together.
Now look at question 29. You hear an optometrist talking to a patient. Now read the question.
Mrs. Wilfred, what brings you here today?
I am having trouble with my vision. I can't see and I need new contacts.
Okay, are you having trouble seeing up close or far away?
I can't see anything. I'm night blind and my eyes very itchy now. I brought my glasses with me and I want you to check them.
Okay, let me check your glasses. I will show you some lenses and just tell me if one of these lenses makes these letters look better.
These aren't working.
Okay, now I'm going to check the health of your eyes. It looks like you have a detached retina and contacts will not help in this situation. You need a surgery.
Can I get glasses instead?
No, Mom. The problem that you are having now will not improve by using glasses.
Can you give me some drops for few months?
No, Mom. Drops will not help with your detached retina.
Question 30. You hear a podiatrist talking about a proposal to offer help with dialysis patients' foot care. Now read the question.
For the last couple of years, we were aware that a lot of the patients who underwent dialysis were at really high risk of developing complications with their feet, especially the diabetic patients. We found that a lot of them were struggling to attend our clinics and access the service. We had to come up with an ingenuity project to try and improve an element of care, and we thought this was a brilliant opportunity to look at the problem that we already identified and see if we could come up with a solution for it. So, we are offering our service to the people who would find it difficult to access our service. It would be really nice as we're making a difference to their life because they don't have to go out on their day off, and they go out 3 mornings a week, and when it's freezing cold.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
Hello everyone and welcome to today's program. I'm very happy that we have Dr. Christina Salem with us to shed some light on a very important topic, diabetes and COVID-19.
I mean, there has been so much on the news about this topic, and it's often hard to get the answers that are important to patients.
Definitely. Filtering through all of the information can be overwhelming. Okay, so let's jump right in. We asked our viewers to send in their most pressing questions about the topic, and so I want to start with the one that is on everybody's mind. Are people with diabetes more likely to get COVID-19?
At this point, there is not enough data to show whether people with diabetes are more likely to get COVID-19. In general, there is so much we do not know, but the problem seems to be for patients with diabetes is worse outcomes, not a greater chance of contracting the virus. For example, in China, where many cases have occurred, people with diabetes had much higher rates of serious complications and death than people without diabetes. Overall, we believe that the more comorbidities someone has, for example, diabetes and heart disease, the higher their chance of getting serious complications with COVID-19.
Interesting point about comorbidities in general. Why exactly are people with diabetes more likely to experience serious complications?
Well, in general, diabetic people are more likely to experience severe symptoms and complications when infected with any virus. In addition, when people do not manage their diabetes well and experience fluctuating blood sugars, They are at risk for a number of diabetes-related complications, and having these complications in addition to diabetes could worsen their chances of getting seriously ill from COVID-19 because their body's ability to fight off infection is compromised. Another point is that viral infection can increase inflammation or internal swelling in people with diabetes. This is also caused by above-target blood sugars, and both could contribute to more severe complications.
What about diabetic ketoacidosis? Do patients with diabetes need to be concerned about DKA?
When sick with a viral infection, people with diabetes do face an increased risk of DKA, commonly experienced by people with type 1 diabetes. Also, DKA can make it challenging to manage fluid intake and electrolyte levels, which is super important in managing sepsis. I say this because sepsis and septic shock are some of the more serious complications that some people with COVID-19 have experienced.
Speaking of type 1 diabetes, are the risks different for people with type 1 and type 2 diabetes?
We don't know of any reason to think COVID-19 will pose a difference in risk between type 1 and type 2 diabetes. More important is that people with either type of diabetes vary in their age, complications, and how well they've been managing their diabetes. This last point of management is key because, like I previously mentioned, what we do know is that people who already have diabetes-related health problems are likely to have worse outcomes if they contract COVID-19 than people with diabetes who are otherwise healthy, whichever type of diabetes they have.
So if a person with diabetes suspects they have COVID-19, what do you recommend that they do?
Well, the first thing is to know the potential symptoms, which include fever, dry cough, and shortness of breath. If you feel like you are developing symptoms, call your doctor. When you make that call, you should have a couple of things on hand: your glucose and ketone readings available, a report of your fluid consumptions, a clear idea and description of your symptoms, as well as specific questions on how to manage your diabetes.
One concern that many diabetics have, especially in light of recent issues with the availability of insulin and other diabetic supplies, is if or how COVID-19 will impact access to these supplies.
At this point, leading manufacturing capabilities for insulin and other supplies are at this time. Organizations like the American Diabetes Association are continuing to monitor the situation and will provide updates should anything change. The most important thing at this moment, when so many people are out of work and struggling, is to know that there is also assistance for anyone struggling to pay for insulin. All you need to do is contact
(37 to 42). You hear an interview with a neurosurgeon called Dr. Ian Marsh, who specializes in the treatment of concussion in sport. You now have 90 seconds to read questions 37 to 42.
My guest today is Dr. Ian Marsh, a specialist in the treatment of concussion in sport, and a co-author on a new set of guidelines. So, Dr. Marsh, what's the aim of these new guidelines?
Well, the aim was really to provide a resource, not for the top-level professional sports people, but for parents, teachers, and coaches of young people playing sport. The guidelines basically offer some expert information from a GP, an emergency physician, and myself as a neurosurgeon about what the condition is, also how to identify the symptoms and how to manage it. If any of your listeners have ever had a concussion doing sports, you'll know how frightening it can be. It's confusing and painful and difficult sometimes for teachers, parents, or whoever to work out if someone with concussion is okay. I mean, we hope to remedy that.
And how do we know when someone is suffering from concussion?
Well, obviously, if the person's actually knocked out, it's clear. But not all patients actually lose consciousness. Often, following a hard knock to the head, they become disorientated or experience headaches, nausea, or vomiting. These are signs of concussion, and they may clear initially, but then return when the individual actually undertakes further physical activity.
Right.
When they start to train, say. So it can actually take quite a while for things to really clear up. The essence of it is that people shouldn't start playing again until those warning signs have completely subsided.
Yes, and you say that waiting anything less than 14 days after all the symptoms have cleared would be too early to return.
Yeah, that's right. If they go back too early, they risk a second concussion. And as we know from professional athletes, they may have to give up their sport if they have too many concussions.
Right.
So it's better, particularly in a young person with a developing brain, to allow all of the symptoms to settle and only then return to play. Well, usually return to train first, then return to play after that. It used to be thought that receiving another concussion could lead to severe brain swelling, and that could be fatal, or at least involve a visit to the emergency room. I think the evidence is fairly slim for that. What we do know, though, is that the compounding effect of having one concussion followed by another seems to be more severe than just the one. So it's always better to let the brain recover fully before playing again.
Right, so who's at the highest risk of sports concussion?
Well, actually, a concussion can happen whenever anyone receives a blow to the head. Usually it's a sort of twisting blow, not a straight-on blow. But obviously, people playing sports like rugby, where there's bodily contact, stand more chance of being at the receiving end of such a blow. But having said that, it's just as likely to affect kids kicking a ball around a park as it is to affect top professional players in big matches.
Do you think that youth sports need specialist concussion doctors on hand, like the professionals do?
There's always a risk, and we know that it happens from time to time. But I mean, most games, even the most dangerous ones, are without incident at all. I think people who are involved in running youth sports, whether they be referees, coaches, or parents, can be made aware of how to manage concussion, the signs that they need to look out for, and maybe the warnings of something more serious so that they can take the appropriate actions. But I think always having a doctor on the sidelines where young people are playing is just an overreaction.
Right. In the USA, college football is big business. They're trialling helmet sensors and impact sensors. Do you think that's something we need everywhere?
Well, I don't think it'll come to that. I think there are two scenarios here. The first is one where a concussion's a one-off event following a significant blow to the head.
Right.
The second's quite different and involves chronic traumatic encephalopathy. This comes about particularly in American football, where players use their helmets and heads almost like weapons. That type of repeated impact seems to add up over the player's career. That's something we've heard being discussed, mostly in the USA. Naturally, there's interest generally in protecting players, particularly in the professional levels of sport, but I see that as a different matter to the management of concussion itself.